Assalamu alaikum. A high-risk tracheostomy is any tracheostomy where standard anatomical exposure of the trachea or safe airway control or predictable surgical steps are compromised. In this presentation, we shall discuss the decision-making for 11 different situations of high-risk tracheostomy. A tracheostomy can be high risk or difficult due to the urgency of performing it, or due to patient factors, or due to the pathology. In this presentation, we shall discuss these 11 different situations: the emergency tracheostomy in a critical airway, and a tracheostomy in morbid obesity, and in neck injuries, or in neck extension difficulties, or in severe neck space infection, or in the case of giant thyroid gland, or aberrant vascular anomalies in the neck, or in head and neck tumors including tumor tracheostomy, or in a post-radiotherapy tracheostomy, or a revision operation, or a pediatric tracheostomy. The etiology of a high risk or a difficult tracheostomy can be classified into two big groups. The first group relates to the time factor. There is a critical airway function, critical airway obstruction, and inability to oxygenate the patient who may have high ventilatory pressures. So that's the first group. Time is the factor here. The second group include other causes for high-risk tracheostomy related to either a difficult anatomy or a difficult surgical environment or a difficult positioning of the patient. In the difficult anatomy, it can be due to distorted neck planes or a deep trachea or obesity or a large thyroid gland or tumor infiltration. In the difficult surgical environment, it can be due to high bleeding risk or an infection in the neck, or prior surgery or radiotherapy, or working outside the operative theater like in the wards or the ICUs. And in the difficult positioning, it's the inability to extend the neck due to neck trauma or cervical spine instability or ankylosis. Time is a crucial factor in the first group of difficult or high-risk tracheostomies, the group of the critical airway. To gain an insight about what is the time required to perform a tracheostomy, a large prospective randomized controlled trial was undertaken, and it found that the time interval required from the start of the procedure to the insertion of the tracheostomy tube and connecting it to a ventilator is about, on average, 10 minutes plus or minus 2.4 in the percutaneous tracheostomy technique, and 15 minutes plus or minus 3 in the open tracheostomy group. So obviously, for a patient who have a very critical airway, you would need to consider oxygenating the patient via other methods during or even before starting the tracheostomy, which may take that long before being able to oxygenate the patient through it. So the first initial step in the management of the high-risk tracheostomies is the initial triage. Is this an urgent or a difficult tracheostomy? If it's an urgent tracheostomy that needs immediate access to the airway, that is one pathway. But this is for critical airway obstruction, and this would take the emergency pathway. But if it is a difficult tracheostomy in a stable patient who is still oxygenating well but have distorted anatomy or in the neck, this would take the other pathway, the elective difficult pathway. The third pathway is that of the pediatric patients. Complications increased between 2 to 5 folds in the urgent situation. So the question of can the airway status of this patient maintain oxygenation? If the answer is yes, this is a difficult tracheostomy, not urgent, and you can proceed with full assessment. But if it is not, if the patient cannot maintain oxygenation. This is an emergency oxygenation pathway, the critical airway, and the first thing to do now is immediate oxygenation to buy time during performing the tracheostomy. This can be done by several ways, including high flow nasal oxygenation or awake fiber-optic intubation, if that's possible, or a rigid bronchoscopy and ventilation under light anesthesia, or jet ventilation, or emergency cricothyroidotomy to bridge the patient over the critical period of airway obstruction. When the patient with the critical airway needs immediate oxygenation, some techniques can be used to buy time to perform the emergency tracheostomy that can take somewhere more than 10 minutes or so. Some of these techniques are the high flow nasal oxygen. This would buy few more minutes by passing oxygen through a nasal catheter, high flow, and some of this oxygen would find its way to the larynx even if there is a tumor obstruction. The use of this type of tubes that has two cuffs that can be inflated, one below the larynx and one in the upper hypopharynx above the larynx. So this inflating these two cuffs would isolate a segment in the laryngopharynx, and in this segment the tube has several holes and pores in here through which oxygen can be passed, high flow oxygen can be passed, and a good proportion of this can find its way to the larynx. Or jet ventilation, which can be useful in near total obstruction, or using things like supraglottic airway and laryngeal mask tubes. These measures are only very temporary and can only buy few extra minutes to perform the tracheostomy. It's not reliable in severe obstruction. Other techniques include the awake fibro-optic intubation, which is the gold standard in distorted anatomy cases, orotracheal intubation under the guidance of a fibro-optic bronchoscope. You pass the scope through the endotracheal tube that needs to be placed, and you try to position the tube in situ through the larynx to gain some time. Or the patient may require a rigid bronchoscopy under light anesthesia, which is excellent for tumor obstruction and allows ventilation and tumor debulking at the same time, and can also guide the tracheostomy procedure by placing the rigid bronchoscope in the trachea. So which oxygenation method you would be using in the critical airway emergency pathway? In a very general terms, with exceptions, if the anatomy is recognizable and the neck is not swollen or distorted, you may try oxygenating the patient while doing a rapid open tracheostomy. But if the anatomy is distorted because of infection or injuries or tumors, the best way is a rigid bronchoscopy under light anesthesia, and through which you can oxygenate, maintain oxygenation or debulk even the tumor and guide the tracheostomy, the open tracheostomy. If it is impossible to recognize any landmarks in the neck due to severe infection or injuries or tumor infiltration, then maybe the best bet is to do a cricothyroidotomy to gain access to the airway, and this would save the oxygenation of the patient and can be converted later once the tracheostomy is performed. Another technique to gain access to the airway and start immediate oxygenation in the critical airway pathway is this, the puncture cricothyroidotomy rather than thyroidotomy. Thyroidostomy refers to just making a perforation, a hole in the cricothyroid membrane through which you can pass a very fine catheter through a large caliber needle and then connect it to a ventilator or an oxygen source. This is the Seldinger technique. This is a percutaneous technique to perform this cricothyroidotomy, access the airway by perforating the cricothyroid membrane. And what you need is a syringe, between 10 and 6 milliliter syringe, filled up with some saline or water, and a large caliber needle in here that is going to cause the perforation, and a guide wire or a soft tissue dilator, and then anything to put through this tiny hole in the membrane. This may be a tracheostomy cannula, a very small cannula, or even a small intubation cannula as well. And the technique is simple. You palpate this cricothyroid membrane by the index finger, but you stabilize the cricoid and the thyroid with the thumb and the middle fingers, and this would give you better control of the area you want to perforate. So you palpate first the cricothyroid membrane, stabilize the cricoid and the thyroid cartilage with the thumb and the middle fingers, and then pass the needle with its sheath around its upper part through the cricothyroid membrane downwards, caudally, with an angle so that it wouldn't hit any, it wouldn't perforate the trachea or the larynx to the outside. And once it is deemed in position, you can aspirate through the needle, and if you can see bubbles in the syringe and the fluid in the syringe, you know you are in the airway. At this stage, you have a needle inside with a sheath. You can push the sheath further and withdraw the needle, and you can actually start oxygenation through the fine cannula that is already in the trachea, and this will give direct oxygen, although through a very narrow cannula. It can still be useful and buy time for the patient. So this is the puncture cricothyroidotomy. But you can also, from this, once you have oxygenated the patient enough, you can now perform the cricothyroidotomy as well, and this is just by withdrawing the needle, keeping the cannula in position, pass a guide wire through the cannula, so the guide wire will be inside, and then you can make a small incision in the cricothyroid membrane, about 2 centimeters at maximum, and this would include the cricothyroid membrane down to the airway itself, and use a tissue dilator to dilate this small incision. And then you can, with the guide wire in place, you can then remove the dilator and the guide wire and put the needle that has been placed around the guide wire into the airway. So you can only puncture and pass the needle and then withdraw it when the sheath of the needle is inside, and oxygenate through this very narrow airway, or you can make it wider by opening up a skin incision and passing a guide wire through the cannula, and then dilate with a tissue dilator the 2 centimeter incision, and pass the if you have an endotracheal tube or a small tracheostomy cannula around the guide wire. Or you can do an open cricothyroidotomy, but you should avoid this in cases of neck injuries with laryngotracheal separation. This operation is again quite simple. You identify the landmarks, the thyroid cartilage and the cricoid cartilage, infiltrate some local anesthetic in the area of the cricothyroid membrane, and make an incision above this area, a horizontal incision in the cricothyroid area. Use dilators to widen this incision, and then you can directly place either a small tracheostomy tube or an endotracheal tube through this hole into the airway to resume oxygenation, and this can be sorted out at once the open tracheostomy is done. The area here can be sorted out, can be repaired again to prevent a permanent hole in the cricothyroid membrane. One other oxygenating technique used more frequently in cases of maxillofacial trauma with an obstructed airway, or in orthognathic surgery or cranial-based surgery when it's either difficult or hazardous to pass a nasal tube or even to pass a high oral tube, is to make a small hole in the submental area through which you can feed the endotracheal tube, and then this can be adjusted to pass through the larynx afterwards, avoiding the unstable or the area that is completely obstructed. And now, if there is enough time, we've tried oxygenating the patient to buy this precious time, and an emergency open tracheostomy can be carried out. The main thing here is first to address the position of the cervical spine precaution. Some of these patients may have cervical injuries or unstable spine, and if there isn't any issue with the spine, you can put a shoulder roll. If there is, you would have to consider alternative positions like a semi-sitting position, sometimes needed for morbid obesity patients. The other thing is palpation of the really important surgical landmarks in this emergency tracheostomy, palpating the thyroid cartilage and the cricoid, so that if the patient oxygenation drops, a cricothyroidotomy can be carried out to buy extra time. This is the best possible landmark for emergency tracheostomy because it is the nearest structures to the skin, and it is, in the vast majority of cases, can be palpated and can be reached quickly. So the open tracheostomy will be carried out here after dissecting for about 2 centimeters, but gaining access to the cricothyroid area can take only few seconds, and we have only to pass few millimeters. Finger palpation of these surgical landmarks is extremely important. Also, sometimes finger dissection is important in cases of very deep dissection to find the trachea or to verify the position of the carotid arteries, for example. The other features of emergency tracheostomy is the skin incision, which should be vertical to allow maximum exposure of the midline structures. These are the important landmarks in this type of operation, and also allow minimal dissection sideways by a vertical skin incision. The pretracheal fascia would have to be cleared, of course. The other point is that the tracheal opening should be also a vertical incision or a flap that is inferiorly based. Again, this would allow direct access to the airway and a way to secure the difficult tracheostomy stoma to the skin, so that the airway would not be lost if the tube has to be changed, for example. The stay sutures around the incisions are important, and fixing the tube by sutures is also important. And avoid a false passage, and this is important in pediatrics and in the obese patient. This would happen if the area between the anterior tracheal wall and the skin is increased by the disease. In that case, debulking of fat or tumor or infected material from this area to allow the trachea to be closer to the skin as possible and obliterate the plane in front of the trachea would reduce the chance of a false passage. Next, we turn to the elective difficult tracheostomy. This is a stable patient who have stable oxygenation, so time is not a pressing factor, but the tracheostomy itself may be a difficult procedure due to various other causes. You can afford to have some pre-operative assessment and setup because time is not pressing. You can afford also to arrange for a senior ENT and anesthetist to be available, and have the difficult airway trolley and a fibro-optic scope and a rigid bronchoscope together with vascular instruments. Blood transfusion products should be available in some cases of anomalous arteries in the neck. And the positioning of the patient. If there is no cervical instability or cervical spondylosis, then the standard extension can be safe with a shoulder roll. But if there is any doubt about this, then the neck should be placed in the neutral position with no extension, particularly in the cervical spine injuries. And in the case of morbid obesity, the patient may be in the semi-sitting position. In the difficult tracheostomy cases, when you still have time because the patient has stable oxygenation, you can afford to have pre-operative preparation in the form of a CT scan of the neck and an ultrasound scan of the neck as well. A CT scan would show if there is a tumor and its extent, or the infection spread and the pockets of the infection, or if there is any vascular anomalies if you have the CT scan done with a contrast. And it can also assess the thyroid size and if there is any retrosternal extension. The ultrasound scan, which can be also carried out in theater, would help to localize the position of the thyroid isthmus during the procedure and the size and the position of the anterior jugular veins and if there is any thyroid edema artery. One of the commonest causes for difficult tracheostomy is morbid obesity. Morbid obesity in adults is defined as a body mass index of more than 40 kilograms body weight divided by the square of the patient's height. And if that's more than 40, then the patient has morbid obesity. It was found that 1/3 of the adults worldwide are overweight, not necessarily morbidly obese, but overweight, and about 50% of adults in several countries also have adult obesity. So it's a fairly common condition. The main anatomical difficulties in the obese neck is that the trachea in morbid obesity will be much deeper. The distance between the anterior tracheal wall and the skin would be in excess of 3 to 4 centimeters rather than just 2 centimeters in normal subjects. There is therefore all this distance would have to be dissected. There is also a higher chance of a false passage because this distance is increased, so a tracheostomy tube can slip into the pre-tracheal area. There is also the risk of obscuring the important landmarks because of the excessive thickness of the subcutaneous fat layer. This can be combined with a short neck and therefore a limited space for the tracheostomy tube, with crowding between the mandible and the sternum, and a chance that a high riding innominate artery would be close to the surgical field. So all these would add to the difficulties, plus of course the difficult in the retraction, a very thick flap because of the depth of the subcutaneous tissue. In morbid obesity tracheostomy, the neck skin incision can still be a horizontal incision if the anatomy is not disturbed, but it should be a vertical skin incision if there is distorted anatomy, like in revision tracheostomies or in cases of infection. And then the dissection of the deep area in front of the trachea, which can be in excess of 3 to 4 centimeters, making sure that you are not going to injure the anterior jugular veins. They are usually distended, and this would have to for this you would have to stay strictly in the midline. There will be difficulty in the retraction of these thick skin flaps, and sometimes you would have to control the anterior jugular veins if they have collateral vessels between them. Strap muscles would then be reached and they have to be separated in the midline and retracted laterally, and the thyroid isthmus would then be exposed. There is a higher chance of accidental decannulation in the obese patient after performing the tracheostomy. The tracheostomy tubes used in obese patients is usually an extra long tube, with the part inside the trachea is now relatively shorter compared to the part of the tube that is outside the trachea to allow for the deep trachea position and the thick subcutaneous tissue. Now, with straining or coughing, the tube can be displaced, and if it is displaced, it can fall outside the trachea into the pre-tracheal space. Or attempts at repositioning the trachea would also carry the risk of placing the shorter intratracheal segment of the tube into this pretracheal very thick layer, and this can lead to a false passage. Another cause for difficult tracheostomy is tracheostomy in neck injuries patient. This may be either a penetrating trauma that has caused an emphysema into the neck planes, or a blunt trauma with accumulation of hematoma into the neck spaces. The main thing here, two things. The first is that a CT scan is usually required if the patient can maintain stable oxygenation. This would be crucial to identify the site of the injury and its level, and also any associated problems like cervical spine instability or laryngotracheal separation. And if there is a laryngotracheal separation, you should not be doing a cricothyroidotomy procedure. CT angiography is therefore of importance, and the other main thing in these patients is to try to identify through the CT scan the level of the injury, and the tracheostomy should be done below the site of the injury. So a CT scan, preferably an angiography, and a tracheostomy that is below the site of the injury, and making sure the cervical spine is stable, and making sure there is no laryngotracheal separation. Next come the tracheostomy difficulties in neck extension problems, like cervical spine injuries or ankylosing spondylitis or halofixation of the spine, or severe kyphosis or neck trauma with unstable cervical spine. The things that should be considered during the management is to maintain a neutral position, no neck extension and no under the shoulders bag, and manual stabilization of the cervical spine sometimes is required during the procedure to avoid any neck extension. The skin incision should be a vertical incision, and that would enable direct access to the trachea with limited lateral dissection and limited need for further neck extension. Bronchoscopy guidance may be of help, even with a flexible bronchoscope, and the tube suture after creating the stoma, stay sutures in the trachea, and suturing of the tracheostomy tube to the skin would be required. And then the difficult tracheostomy in severe neck space infection in patients who may have Ludwig's angina, necrotizing fasciitis, retropharyngeal or parapharyngeal abscess, like in here. In these cases, the principles are first to drain the abscess, particularly if it is a localized single abscess. This is the first step after securing the airway by endotracheal tube, for example. If this cannot be achieved, you need to consider alternative airway. If the anatomy is unsafe, you would need to consider doing other ways to, like, for example, a rigid bronchoscopy. So which will allow a stable airway until the abscess is first drained. And you should expect marked edema and friable tissue in the neck, so bleeding should be controlled early, one by one. A vertical skin incision is usually preferred for the tracheostomy, which would allow better access to a longer segment of the neck to drain the abscess, and also for the carrying out of the tracheostomy. You should have a good exposure, but avoid blind dissection, and avoid extensive unnecessary dissection that may open up further planes for the infection. The trachea should be identified. Sometimes you need to identify it by placing a needle inside and aspirating air into a syringe filled up with saline or a fluid. And sometimes bronchoscopy, rigid bronchoscopy, is the answer for securing the airway. An ultrasound scan intraoperatively can also be valuable in localizing the pockets of pus and localizing the position of the trachea. And then the difficult tracheostomy in a giant thyroid gland. The giant thyroid gland may cause tracheal deviation of the midline to one side, or tracheal compression as well, and engorged neck veins, particularly affecting the anterior jugular veins, a bulky thyroid isthmus covering the anterior wall of the trachea where you want to perform the tracheostomy, sometimes a retrosternal extension of the thyroid gland, and this may also there may be also a thyroid ima artery hidden by the giant thyroid gland. So there is generally increased vascularity of the field and a risk of profuse bleeding, plus poor exposure of the trachea and the displacement of the neck vessels, the carotids, and the interior and the internal jugular veins as well. For the thyroid isthmus management, which may be very bulky in the case of a giant thyroid, if the thyroid isthmus is very small, it can be retracted superiorly to expose the anterior wall of the trachea. But in the vast majority of cases, it is bulky and need to be dissected of the anterior tracheal wall and divided between clamps and then transfixed to expose the anterior tracheal wall. Sometimes also you would have to debulk the thyroid. Even a partial thyroidectomy may be required, although this is rare, to expose the anterior part of the neck, expose the anterior tracheal wall, and remove any tracheal tissue in between the skin and the trachea to avoid any false passage when the tube is displaced. If there is a retrosternal giant thyroid, and attempts at mobilizing it superiorly, but not by blind division, should be considered. Next comes the difficult tracheostomy because of aberrant vascular anomalies. One of the commonest causes for this is the thyroid ima artery in the anterior tracheal wall. This could come out from the innominate artery or the arch of the aorta directly, or even from the right carotid artery. In all these cases, the thyroid ima artery would lie in front of the anterior tracheal wall and would be vulnerable to injury and profuse bleeding during the procedure. Other causes of massive bleeding during tracheostomy would be a high innominate artery, like in this case, when it is lying in front of the tracheal wall, higher up in the neck, or an ectatic carotid artery that may be misplaced in front of the trachea or closer to the surgical field. And then other less serious problems like a dilated anterior jugular veins or post-radiotherapy vascular changes or venous anomalies in the neck, but you may also have a retrosternal innominate artery. The best management for this aberrant vascular anatomy in the neck is identification and avoidance, preferably preoperatively by a preoperative CT scan angiography and a color Doppler. And if these aberrant vessels are identified, then a low tracheostomy can be avoided. You will place your skin incision higher up in the neck, away from the possible problems associated with a high innominate artery or a thyroid ima artery, which usually covers the lower part of the tracheostomy area. Sometimes a sternotomy may be required to expose the superior mediastinum, and of course you would have to be prepared for management of a catastrophic bleeding. Identification of the high innominate artery is crucial. also identification of a thyroid aorta would save some profuse bleeding in the anterior tracheal area, and the anterior jugular veins should be ligated or identified early and avoided, and deep dissection, particularly inferiorly or laterally, should be avoided in the tracheostomy to avoid encountering these aberrant vessels. And next are the difficulties with tracheostomy in head and neck tumor cases, where the anatomy may be distorted, particularly with extralaryngeal or extratracheal or thyroid tumors. And sometimes there may be also tracheal deviation due to the tumor spread, or tumor infiltration directly into the airway or anterior to the trachea into the strap muscles. There is an increased risk of tumor bleeding either in the neck or in the airway, and a very serious risk of tumor seeding of the tract of the tracheostomy with a stomal recurrence. The tumor should be mapped before the operation by a CT scan, and a level for a tracheostomy below the level of the infiltration should be ideally chosen to avoid any tumor seeding or any hemorrhage from the tumor. The rigid bronchoscopy can be of great value during anesthesia to provide a secure airway and a port for ventilation by venturi, for example. And at the end of the procedure, the tracheostomy tube should be fixed in position. There will be stay sutures at the trachea and fixation of the trachea tube to the skin to avoid any displacement. It may be better here to do a horizontal neck incision, but large enough to provide adequate exposure for a displaced trachea that may be shifted, so the incision should be properly adjusted in the neck and large enough to allow this very good exposure. Now, the dissection from the skin to the anterior tracheal wall may be straightforward if the strap muscles are not invaded, then they should be retracted laterally, but if they are invaded, they must be resected with the part of the tumor debulking. It's important here to identify the position of the thyroid cartilage, because this is a very important anatomical landmark to identify where the trachea would be away from the midline. The tumor mass may be debulked once it is reached in the area anterior to the trachea, and this would allow an exposure of the anterior tracheal wall to search for a viable tracheal area for the stoma. The important thing here is to reach the anterior wall of the trachea, and one should consider whether any tumor tissue crossing in front of the anterior wall of the trachea can be resected, like in a partial thyroidectomy or isthmothectomy. Just debulking of any tumor tissue in front of the tracheal wall to get better exposure to put in the stoma, and also to avoid any false passage if the tube gets decannulated later. The other thing, of course, is that sometimes with these bulky tumors in the neck, there may be anomalous large blood vessels, either displaced carotids or big engorged anterior jugular veins. Also, the tumor tissues can be friable and bleed easily, so bleeding has to be stopped early, and dissection would have to proceed very cautiously to avoid these. If it is not possible to remove the whole tumor in front of the trachea, then it should be thinned out by electrocautery as a debulking procedure. Palpation of the carotid artery position is important during carrying out this step, because sometimes the carotids can be displaced quite close to the surgical field. When there is tumor invasion of the trachea and tracheostomy is required to secure an airway, fixation of the trachea to the skin by creating a flap, an inverted U-turned flap from the tracheal wall to the skin would secure the position of the trachea close to the cervical skin and avoid any false passages. This is usually carried out by an inferiorly based flap. And then another possible technique that can be done would be an H-shaped tracheal incision, and this would also create smaller flaps. Some of them can be sutured to the lower lip of the tracheostomy incision, and the others could be sutured to the upper lip of the incision. The difficulties with tracheostomy in post-radiotherapy neck is the extensive fibrosis, the poor healing of the tissue, the hypovascularity, the exposure of the displacement of the carotid arteries by the extensive fibrosis, the risk of osteoradionecrosis, and the risk of delayed healing. And the general lines of management for this tracheostomy would be a wider than usual incision in order to gain access and good exposure of the structures in the neck that may have been displaced by the fibrosis, gentle handling of the tissues to avoid any necrotic tissues that may be anidas for infection and osteoradionecrosis, meticulous hemostasis, and leaving around vascularized tissue that may provide some hope for good healing. And the tube should be fixed to the skin after the tracheostomy to avoid any displacement. The difficulties with a revision tracheostomy includes scarred tissue planes, loss of the normal anatomy, and tracheal deformity, including weakening of the anterior tracheal wall, and granulation tissue at the site of the previous stoma, and sometimes also infection of this area. The general lines of management here would include a preoperative CT scan. This is important. And rigid bronchoscopy, or if not possible, a fiber-optic guidance would also be important in this type of procedure. It would start by using the previous stoma as a guide and trying to find the old tract that may lead to the anterior tracheal wall. You would, of course, expect scarred tissue planes, and a vertical incision would therefore be preferable. The dissection should be limited to the midline and avoid any lateral dissection. There is a high risk of false passage, and for stay sutures should be inserted at the edges of the vertical skin incision, a vertical incision in the anterior tracheal wall to allow for easy replacement of the tracheal tubes. Finally, the difficulties with a pediatric tracheostomy is that you have a very narrow margin of error. They have a peculiar type of physiology and a reaction to trauma and stress, and also the important structures are crowded in a smaller area, so there is a narrow margin of error. The skin incision preferred is usually a vertical skin incision, which would limit dissection in the midline area or quite close to it. There may be difficulty in identifying the position of the trachea because it is very soft, and a rigid bronchoscopy may be helpful if it is in the trachea to help in identifying its position. The trachea is also highly mobile, and the bronchoscopy would help in stabilizing it. The cartilage may be very soft, and the tracheal cartilage, and there is a higher risk of a false passage. So you need a vertical incision, minimal lateral dissection, and a vertical incision in the trachea. You shouldn't be using any tracheal flaps here. Minimal disturbance of the tracheal cartilage by just a slit in the midline, a vertical slit, and stay sutures to the right and left of this slit. And be aware that the pleura the apex of the pleura is quite close, and there is a higher risk of pneumothorax in this type of procedure. By this, we come to the end of this presentation on high-risk tracheostomy, the urgent and the difficult tracheostomy. Assalamu alaikum.